The topic today we'll be dealing is about hypersensitivity. Till now we have been dealing about the immune responses, how protective is the immune response against different types of antigens or the organism. So as a coin has two sides, similarly the immune response also shows the two sides, where one side is the protective role that it usually helps us to fight against the different types of organism. The other side of it is to develop an exaggerated immune response that is usually harmful to the human body. So here in this hypersensitivity reaction, the immune response towards a particular allergen or an antigen develops an exaggerated immune response that causes a damage to the host, even leading to the death of the person. So hypersensitivity is nothing but the exaggerated immune response towards a particular antigen, especially the allergens in sensitized individuals. So I'm using the word here sensitized, means it is not taking place in all the individuals. There are certain individuals who are allergic towards certain components. So in those sensitized individuals, the common antigen or the allergen can induce an exaggerated immune response, which is called as a hypersensitivity reaction. So hypersensitivity reaction is nothing but exaggerated immune response towards a particular antigen. Especially we will mention the term allergen over here rather than antigen, because antigen can be any organism, but here the common substances that are present in the environment can induce this hypersensitivity reaction. So they are usually termed as allergens and usually takes place in only the sensitized individuals. So as the immune reaction is protective in a normal individual, sometimes this immune reaction can go awry and cause an exaggerated inflammatory reaction in the sensitized individual, causing hypersensitivity reaction. So here the most important thing is it is not taking place in all the individual but only in sensitized individual. And in case of this hypersensitivity reaction, the antigen is of little concern. It is usually a bland substance like serum or a pollen, etc. So it is not any bacteria or virus that is usually inducing the hypersensitivity reaction, but it is a common substance that is present in the environment which is able to induce the hypersensitivity reaction. So the main concern in this hypersensitivity reaction, it is the individual but not the allergen, whereas in the immune response the main concern will be the antigen, whether it is a bacteria or a virus, and is the main concern will be how to eliminate this bacteria and virus from that particular individual. But in case of hypersensitivity, the main concern is not about the antigen, but the main concern is about how the immune response is exaggerated in a sensitized individual. So the main concern here will be completely shifted to the individual, how he is able to develop the immune response towards a particular common substance of the environment. So in the case of immune response in a normal individual, the main concern will be the antigen, but here the main concern is the host, how is he responding towards a particular allergen. So here the antigen is innocuous or a bland substance. It can be a very simple substance that can induce the hypersensitivity reaction. So initially the term allergy was used to denote these hypersensitivity reaction, but now we come to know that it is only a part of hypersensitivity reaction and it is only a component of the hypersensitivity reaction, or you can say it is a clinical manifestation of a hypersensitivity reaction. So apart from the different types of hypersensitivity reactions that usually takes place in a sensitized individual, allergy is one component. So initially it was used as a synonym for hypersensitivity reaction by von Burgert, but later on we have seen that allergy is only a component of type 1 hypersensitivity reaction, and apart from this allergy there are different types of hypersensitivity reaction that can be developed in a sensitized individual. And the most important thing to know about how this hypersensitivity reaction develops in an individual is the most important thing to activate the immune response to go exaggerated is the allergen. So the individual has to contact with the allergen, and the initial contact with the allergen is called as a sensitizing dose or a priming dose. That does not cause any type of clinical manifestation. So it only helps to activate the immune system, helps to prime the lymphocyte, that is a B lymphocyte or a T lymphocyte, and later on a subsequent exposure with a similar type of antigen or the same antigen, you can see the clinical manifestation of hypersensitivity reaction. So in order to induce an hypersensitivity reaction, you need three important things. One is the allergen, that can be any common substances from the environment, and the most important thing is the sensitized individual. It is not all individuals in which you can see the hypersensitivity reaction, but there are certain human beings that are sensitive towards these common allergens of the environment. So allergen, we need a sensitized individual, and the first dose of the allergen that usually enhances the immune system, which is called as a priming dose, and the next dose, which is a subsequent dose, also called as a shocking dose, that usually manifests the hypersensitivity reaction. So hypersensitivity reaction, on a summary, I can say that it is an exaggerated immune response in a sensitized individual towards a common allergen but not a antigen. So now how can we classify this hypersensitivity reaction? As I told you, there are different types of hypersensitivity reaction, allergy being one important component of this hypersensitivity reaction. So depending upon the clinical manifestations of the symptoms, how long do they take to show their response, you can classify the hypersensitivity reactions into two major types. One is a immediate hypersensitivity reaction, the other one is a delayed type of hypersensitivity reaction. So immediate, the differences between the immediate and delayed, as the name itself indicates, immediate is you can see the symptoms of the clinical manifestation as soon as the allergen contacts the sensitized individual. That is, it appears, and it also has the ability to recede immediately. So it appears and recedes immediately in immediate type of hypersensitivity reaction. Next is the allergen or the hapten. Hapten can also induce this immediate type of hypersensitivity reaction. So they can enter the human host, that is a sensitized individual, by any route, that is either by the ingestion or the inhalation, or they can be introduced via the intradermal, subcutaneous, etc. But the most prominent route which usually activates this exaggerated immune response, that is the immediate hypersensitivity reaction, is either ingestion or the inhalation. So allergen can enter the sensitized individual and can develop the immediate type of hypersensitivity reaction by any route. Next is this immediate type of hypersensitivity reaction belongs to the humoral immune response. Now the humoral immune response is nothing but the antibody mediated immune response. So it is the antibodies that are usually involved in this type of hypersensitivity reaction. So this can also be said as antibody mediated hypersensitivity reactions. So there are different antibodies, as we know. There are IgG, IgA, IgM, IgD, IgE. But the most prominent one that induces the hypersensitivity reactions are the IgE and the IgG antibodies. And this type of hypersensitivity reaction can be passively transferred from one individual to the other individuals, one sensitized individual to the other sensitized individual, by transfer of the serum which contains the antibodies. And here, in case of immediate type of hypersensitivity reaction, the desensitization is very easy, but it is a short-lived. And now coming to the delayed type of hypersensitivity reaction, here as the name itself indicates, there is a delay in the appearance of the clinical syndromes in case of this delayed type of hypersensitivity reaction. So immediately, as soon as the sensitized individual contracts with the allergen, you will not see the clinical manifestation. It is very slow to develop this delayed type of hypersensitivity reaction, but the problem here is it lasts for a very longer time. And here the antigen or the allergen can induce the hypersensitivity only when introduced via the intradermal, that is via the skin. And the things that usually activates this type of delayed hypersensitivity reaction are not the circulating antibodies but the cell mediated. It is the one that belongs to cell mediated. That means the T lymphocyte. It can be either the T cells or the TC cells that can activate the delayed type of hypersensitivity reaction, or you can say that the clinical manifestations of the hypersensitivity or the delayed type of hypersensitivity is because of the cell mediated immunity. Now next, you cannot transfer the delayed type of hypersensitivity with the serum because no serum is involved here. So you can transfer this delayed type of hypersensitivity with the help of T transfer, that is the T lymphocyte transfer. And desensitization is not very easy, and it is very long lasting. So this is the difference between the immediate type of hypersensitivity reaction and the delayed type of hypersensitivity reaction. So to say it very simple, immediate is brought about by the humoral immune response, whereas the delayed type of hypersensitivity is usually brought about by the cell, that is the T lymphocyte or the cell mediated immune response. Now there are clinical manifestations that are associated with the immediate and the delayed type of hypersensitivity reactions are: in immediate hypersensitivity reaction, anaphylaxis, atopy, antibody mediated cell damage, you can see the Arthus reaction and a serum sickness. So all these things are the one that are due to the manifestation of the immediate type of hypersensitivity reaction. Now coming to the delayed type of hypersensitivity reaction mediated by the T cell, it is the infection or the tuberculin or the contact dermatitis. Contact dermatitis towards any type of chemical or a drug, etc. So when they contact with the skin, they can induce this delayed type of hypersensitivity reaction. So that is nothing but a contact dermatitis. So the different clinical manifestations are categorized depending upon how long do they take to show the clinical syndromes or the symptoms. So it was Gels and Coombs who helps us to classify these different types of clinical manifestation depending upon the mechanism, how they are usually making it pathogenic in case of hypersensitivity reaction into 4 types. That is a type 1, type 2, type 3 and type 4. So immediate and delayed can be categorized based upon the mechanism of the pathogenesis into 4 different types, that is type 1, type 2, type 3 and type 4. So type 1 is usually mediated by IgE antibody. So reagenic antibody is the one that usually induces this type 1 hypersensitivity reaction. Type 2 is mediated by IgG antibody. So here you can see vast varieties of cells that can be damaged with the help of IgG antibody. Type 3 is immune complex mediated hypersensitivity reaction. So what is an immune complex? Immune complex is nothing but when an antigen enters into the human body, the immediate thing that is produced against the antigen are the antibodies. Now there is a complementarity between the antigen and the antibody that helps them to go and bind to the antigen and activate the other cells of the immune system to eliminate the particular antigen. So the first thing that is formed in the body are the immune complexes. So it is between the antigen and the antibodies. Now these antigen antibodies also have the ability to develop type 3 hypersensitivity reaction. So type 3 is mediated by immune complexes. Now coming to the type 4, as already discussed, type 4 is mediated by T lymphocytes. So here the culprits will be the T cells, either the TH cells or the TC cells. So type 4 is cell mediated hypersensitivity. So type 1, type 2, type 3 and type 4. So these are the 4 type of hypersensitivity reaction that can be, where we can easily categorize the clinical syndromes, and based upon the mechanism we can classify them into 4 different types. So it was Gels and Coombs who had given a classification of type 1, type 2, type 3 and type 4. So I'll go with a brief overview of how these 4 hypersensitivity reaction usually takes place. So here coming to the type 1, as already discussed, it is a IgE mediated hypersensitivity reaction, and this IgE is also called as a reagenic antibody or reagenic dependent type 1 hypersensitivity reaction. Now in a normal individual, the concentration or the level of Ig antibody is very less, but in sensitized individual you can see there is an enhanced production of Ig antibody towards a common allergen. So whenever a common allergen such as a pollen or a milk or a hay enters into the sensitized individual, the sensitized individuals, instead of producing IgG antibodies, they produce IgE antibodies more in number, and these IgE antibodies have the Fc receptors on the mast cells and the basophil cells. Now they go and bind to these mast cells and the basophil cells, and they causes sensitization of these mast cells and the basophil cells. So this is a priming dose. In the initial contact, effect does not cause any clinical manifestation. As I told you, it is only the secondary dose or the subsequent exposure to the similar type of antigen, which is called as a shocking dose, that usually shows the clinical manifestation of the hypersensitivity reaction. So once the IgE antibodies are produced towards a common allergen, they go and bind to the mast cells and the basophil cells. They sensitizes the mast cells and the basophil cells. Now on subsequent exposure to the similar type of antigen, the antigen will cross-link the antibodies that are already present in the mast cell and the basophil cell and causes the degranulation of the mast cells and the basophil cell, releasing pharmacological active agents. Now these pharmacological agents are the one that usually shows the clinical manifestations of hypersensitivity reaction. Mostly the clinical manifestation associated with type 1 hypersensitivity reactions are the smooth muscle contraction and increased vascular permeability. So it is type 1 that is usually mediated by IgE antibody in the sensitized individual who are more prone to produce IgE antibody rather than IgG antibodies. Now next, coming to type 2 hypersensitivity reaction. Type 2 hypersensitivity reaction is mediated by IgG antibodies and very rarely it is by IgM antibodies. Now these IgG antibodies have the Fc receptors on the cell surface or the tissue antigens. Now when these antibodies go and bind to the cell surface antigen or the tissue antigen, they causes the lysis of these cells by activating the complement system or the mononuclear cell, that is they enhance the phagocytosis by eliminating the self cells. So here this type 2 hypersensitivity can be said as the intermediate between hypersensitivity and autoimmunity. So there is a thin line between hypersensitivity and autoimmunity. Hypersensitivity is an exaggerated immune response where the inflammatory response produced in the human host usually destructs the individual not to very great extent. But in case of autoimmunity, the antibodies are developed towards self-antigen and causes complete destruction of the self-antigen. So this type 2 hypersensitivity is an intermediate between hypersensitivity and autoimmunity. Now what are the target cells in type 2 hypersensitivity reactions? Are mostly the RBCs that are of the self body are usually the target. So IgG antibodies are produced against the self RBCs, thereby eliminating the RBCs, causing different types of anemias, which is called as the hemolytic anemias. Now apart from the cells, you also have different tissues of the body that can also be the target for the IgG antibodies. And next is sometimes these antibodies, what they do is they go and activate certain hormones of our body, and they see to it that they are excessively produced. So these type of antibodies are called as the agonist antibodies and the antagonist antibodies. So they enhance the production of more amount of the hormones, especially the thyroid cells are usually affected with this IgG antibody. They act as long-acting stimulating or a long-acting thyroid stimulator antibodies. They go and bind to the hormone receptor and they see to it that more amount of thyroid hormones are produced in excess. That is also deleterious to the human body. Apart from that, these antibody can also act as blocking antibodies. That is, they go and bind to the receptor and they see to it that no hormone is produced. So these antibodies that are produced, that is the IgG antibody that mediates type 2 hypersensitivity reaction, can destruct the cell surface antigen or the tissue antigen by activating the complement system or the mononuclear cell, and can target different component of the sensitized individual. Now coming to the type 3 hypersensitivity reaction. This hypersensitivity reaction is mediated by the immune complexes, that is antigen antibody complex, that are formed following contact with the allergen. So mostly it is said that the heterologous serum is the one that usually mediates this type 3 hypersensitivity reaction. So apart from the heterologous serum, you can also see certain types of antibiotics or the drugs that also also can produce more amount of this type 3 hypersensitivity reaction. So these immune complexes that damages the cell, usually the small blood vessels, they go and bind to the endothelial cells, and they see to it they completely damage the endothelial cell, or they can interfere with their function. So the clinical manifestation in type 3 hypersensitivity reaction are Arthur's reaction and the serum sickness. So mostly developed against the heterologous serum. Now coming to the type 4, which is also a delayed type of hypersensitivity reaction mediated by the T cells. Here the cell mediated response is towards the different part of the body. It can be either a generalized one, or it can be a systemic hypersensitivity reaction, and the T cells that are usually involved are the one that contains the receptor of CD4 and CD8 cells, and they are other ones. When they get activated, they can release the lymphokines following contact with the allergen, and then they help in the fluid accumulation and the phagocyte accumulation. Due to the excessive accumulation of the fluid and the phagocyte, you can see granulomas that can be formed, and they are the one that usually interacts with the common allergen and induces this cell-mediated type of hypersensitivity reaction. Now let us go in detail of how the mechanism usually takes place in developing these all 4 type hypersensitivity reactions, that is type 1, type 2, type 3 and type 4. So let us discuss in detail about type 1 hypersensitivity reaction, which is IgE dependent. Now this type 1 hypersensitivity reaction can be classified into 2 major types. One is called as the systemic anaphylaxis, and the other one is a localized atopy. So in the systemic anaphylaxis, you can see it as a acute fatal, which is very dangerous in case of the individual, sensitized individual who develops this systemic type of anaphylaxis reaction. Whereas the localized reactions are usually the non-fatal, recurrent, and they are localized. They are localized only to the place where the allergen usually gains an entry into the individual host or the sensitized individual. And here coming to the anaphylaxis, it was first the Richard who had seen how these type 1 hypersensitivity reaction was developed in dogs, and he proposed the concept of this anaphylaxis as saying as without protection. So instead of the dog developing immunity to a particular toxic component, it has become sensitized. So that made him propose this concept of type 1 hypersensitivity reaction. And here it is usually taking place only in the sensitized individual, and the antigen can enter parenterally, the most important route of allergen entry is the parenteral, and it can also be entered into the sensitized individual via the ingestion or the inhalation that can develop the type 1 hypersensitivity reaction. And a minute dose of the allergen is enough to activate or cause the clinical manifestation of class 1 hypersensitivity reaction. And the most important thing over here is there should be interval between 2 to 3 weeks between the priming dose or the primary dose and the shocking dose to show the clinical manifestation. And the shocking dose is effective when given intravenously. So the primary dose of the allergen can enter via any route, that is whether ingestion, inhalation, or it can be parenteral. But here in case of shocking dose, you can see a heightened type 1 hypersensitivity reaction or the clinical manifestation of type 1 hypersensitivity reaction when it is given intravenously. And the shocking antigen is very important. A very minute dose of the shocking antigen is enough to activate the clinical manifestations of type 1 hypersensitivity reaction. Now the effects that can be seen by the shocking dose of this allergen is it induces smooth muscle contraction and also increases vascular permeability. And it has the ability to affect different organs of a particular species. So these organs or the tissues are called as the shock target tissues or the shock organs. And apart from smooth muscle contraction and increased vascular permeability, the other clinical manifestation related to type 1 hypersensitivity reactions are edema, decreased coagulability of blood, fall in BP, temperature, leukopenia and thrombocytopenia. And there is a species variation towards this type 1 hypersensitivity reaction, where the guinea pigs are highly susceptible to type 1 reaction, and next coming the rabbits, and the humans humans are very rarely affected with this type 1 hypersensitivity reaction. That is, the fatal anaphylaxis is very least or very rarely seen in the humans, but sometimes the sensitized individual shows the symptoms or the clinical manifestation of this type 1 hypersensitivity reaction. The symptoms associated with this type 1 hypersensitivity reaction is itching of the scalp and tongue, there is a flushing of the skin, the bronchial spasm because of the arrest of the respiratory tract, and then you have acute hypotension, loss of consciousness, and ultimately leading to the death if not treated immediately. So initially it was heterologous serum that was thought to be culprit towards this type 1 hypersensitivity reaction in human individuals, but nowadays we can see this type of reaction with the antibiotics or the drugs and even the insect stings. The treatment the prompt treatment that can be given for this type 1 hypersensitivity or the anaphylaxis reaction is the adrenaline. So adrenaline usually neutralizes these type of symptoms that are associated with type 1 hypersensitivity reaction and try to reduce the production of IgE antibodies. So here we have the mechanism that is involved in the IgE antibody production. So in a normal individual, as I already discussed, the IgG antibody is the one that protects the person from a allergen or the antigen. But here in case of this atopic individual, IgE antibodies are usually produced in more amount, and they go and bind to the mast cells and the basophil cells, causes the desensitization of these cells, helps in releasing the pharmacological active agent upon the secondary exposure to the similar type of allergen. And here you have cutaneous anaphylaxis, that is a test usually done to check whether a person is allergic towards a particular component or not, especially the anaphylactic reaction. So here the allergen is introduced intradermally at a small place, a very minute dose of the injection is given along with the allergen, and the positive effect can be seen as a local wheal and flare reaction. So wheal is a pale central edema and surrounded by hyperemia and erythema. So this is called as a flare. So wheal and flare reaction is usually seen only in a sensitized individual and helps us to detect the sensitized individual towards a particular allergen. So it is a skin test for a particular type of allergen towards which the individual is allergic, and usually seen in atopic individuals but not in all individuals. So the sensitized individual here are referred to as atopic individual. Now apart from that, you can also carry out other tests to detect the allergen towards which a particular person is allergic. So it is called as a passive cutaneous anaphylaxis, and it is an in vivo method to detect the allergen. So here mostly this passive cutaneous anaphylaxis is done to detect the antibodies, mostly the IgG antibodies. So initially the antibody is introduced at a particular area on the skin, and after 4 to 12 hours of an interval, the antigen along with the Evans blue is introduced, and you can see a local wheal and flare reaction which is visible in blue line. So blue colored reaction can be seen, which indicates the production of the hypersensitivity reaction. So this passive cutaneous anaphylaxis is mostly used to detect human IgG antibody which are heterocytotrophic. Heterocytotrophics are nothing but the antibodies that can bind to the cells of the other species also. IgE is homocytotrophic, that binds to the cells of the similar species, but this IgG antibody can also go and bind to the cells of the other species. So the passive cutaneous anaphylaxis is mostly used to detect the IgG antibodies. Apart from that, you can also carry out the test for anaphylaxis in vitro. In vitro is in the laboratory condition. So the phenomena is called as a shell stare phenomena, where the isolated tissue antigens are usually taken from the experimental animal and they are placed in a ringer solution, and to this the allergen is usually added. So when there is a shrinkage, you can see a positive effect towards a specific antigen. So this is how the anaphylaxis is usually detected in vitro conditions. So it was devised by Schultz and Dale, and hence it is called as a Schultz-Dale phenomena. Now coming to the mechanism of this anaphylaxis, as already discussed, the IgE antibodies are produced in in the sensitized individual in place of IgG antibodies. They go and bind to the mast cells and the basophil cells, and upon the shocking dose contact, the allergen goes and cross-links the two antibodies that are already bound to the mast cells or the basophil cell. Now the cross-link helps the calcium ions to get inside the mast cells and the basophil cells. Now these mast cells and the basophil cells now starts degranulating to produce the pharmacological active mediators. Now these are the pharmacological active mediators that are the culprits in the type 1 hypersensitivity reaction, or the one that are involved in type 1 hypersensitivity reaction. So different mediators that are produced after the degranulation of the mast cells and the basophil cells, that shows the clinical manifestation of type 1 hypersensitivity reaction. So the mediators of anaphylaxis reactions are primary mediators and the secondary mediators. They are usually classified based upon their production. Primary mediators are the ones that are already produced in the mast cell. They are already present in the granules of the mast cell, whereas the secondary mediators are produced upon the activation or upon the sensitization of this mast cells or the basophil cells. So among the primary mediators, the most prominent ones are the histamine, serotonin, eosinophilic chemotactic factor, neutrophilic chemotactic factors. You have heparin and proteases or proteolytic enzymes. Next are the secondary mediators, which are usually produced only upon the activation. That is, when the cells get sensitized upon primary dose, after the shocking dose, at that particular time these mediators are usually produced. And the examples of that are prostaglandins, leukotrienes. You have platelet activating factors, and the cytokines that are involved over here are interleukin 3, interleukin 4, interleukin 5, interleukin 6, GM and CSF. Now coming to the primary mediators that are the one that are produced that are already present in the granules of the mast cells and the basophil cells. The histamines are the most prominent one that shows the clinical manifestation of this type 1 hypersensitivity reaction, especially in humans, whereas the others are involved in the clinical manifestation of the experimental animals or the rats or the rabbits, etc. So histamines are mostly seen in the humans. So histamines are nothing but they are the components that are present in the mast cells and the basophil cells, and they are produced by the decarboxylation of the histidine during the anaphylactic reactions, and these are released in the sensory near the sensory nerves, due to which there is an itching or hyperemia at that particular area wherever the histamines are usually released in the body. Now they are the one that causes the vasodilation of the different parts of the body, and they can also induce hyperemia and edema. Apart from the smooth muscle contraction, and they also have the ability to produce more amount of components, which is called as a secretocoque effect. Enhanced secretions can be seen of the mucus or the other important components of the human body. So it is called as a secretocoque effect. Next is serotonin, which is a 5-hydroxyl tryptamine produced by the decarboxylation of the tryptophan in the intestinal mucosa, brain tissue and the platelets, and it causes the smooth muscle contraction, increased vascular permeability, vasoconstriction, and mostly lethal in rats and mice. So this do not have effect in the human beings. Next are the chemotactic factors, eosinophilic chemotactic factors and neutrophilic chemotactic factors. So here in the eosinophilic chemotactic factors, these are nothing but they are acidic tetrapeptides that are present in the mast cells and the basophil cells, and when released they causes the chemotaxis of the eosinophils. So they enhance production of eosinophils in the human body in the sensitized individuals. So apart from that, neutrophilic chemotactic factors are the one that enhances the production of neutrophils, and they causes the chemotaxis of the neutrophil or causes the neutrophilia. Next is the heparin. Heparin is an acidic glucopolysaccharide mostly seen in the dogs but not in individuals, that is a human individuals. Apart from that, enzymes also mediate the hypersensitivity reaction, that is anaphylaxis. They are the proteases and the hydrolases. Now coming to the secondary mediators, as already discussed, these mediators are produced upon the entry of the shocking dose. So they are not already prepared and kept in the granules, but they are produced during the degranulation process. That is, they are called as prostaglandin and leukotrienes, and these prostaglandins and leukotrienes are produced from the same substance, that is arachidonic acid, via different pathways. So the lipoxygenase pathway produces the leukotrienes, whereas the cyclooxygenase pathway produces the prostaglandins. So among the leukotrienes, mostly there is SRS-A, that is slow reacting substance A, that is mostly seen in the lungs, and it shows a very slow reaction towards a particular type of allergen, but it is a long lasting one. And apart from that, you have leukotriene B4, C4, D4 and E4. Next, coming to the prostaglandin, the F2 alpha and thromboxane, they are the transient bronchoconstrictor, and they are the one that usually produces or enhances the mucus secretion in the sensitized individuals. Now coming to the other mediator, that is the platelet activating factors. These are the lipid substances present in the platelets, and they are the one that are released by the basophil cells and causes the activation of the platelet. That is, they activate the platelets and enhances the production of the clinical manifestation of type 1 hypersensitivity reaction. And this causes the aggregation of the platelet, which releases certain vasoactive amines. Now, apart from these mast cell mediators released from the mast cells and the basophil cells, you can also see the other mediators that contributes to type 1 hypersensitivity reaction. They are nothing but the mediators that are produced during the complement activation, bradykinin, etc. So complements are nothing but the serum proteins that usually brings about the lysis of the antigen in combination with the antibodies. So there are three pathways by which the complement can be activated, that is the classical, lectin and the mannose binding pathway. So during this pathway, you can see the two subunits that are formed. The larger subunit takes part in the complement system, whereas the smaller subunit are the one that behaves as anaphylatoxin, that induces the anaphylaxis reaction. And apart from that, you can also see anaphylactoid reaction. So these reactions are usually seen in the normal individuals, not in the sensitized individual, but normal individual. When they are injected with certain types of protein, they show similar type of anaphylaxis reaction, but this anaphylactoid reaction is a complete non-immunogenic in nature. It is not immunogenic as seen in case of type 1 hypersensitivity reaction, but it is a non-immunogenic basis reaction, but the clinical manifestations are very much similar to that of the anaphylaxis, but it is not a type 1 hypersensitivity reaction. Now coming to the atopy. Atopy means is out of place. According to certain scientists, atopy refers to out of place. That is, it was Koka who has given us a concept that it is not all individual that produces the hypersensitivity reaction towards the common allergen, but there are certain sensitized individual that has the ability to show this anaphylaxis reaction towards the common environmental pollutants such as the pollen or the hay, or you can see the milk. So when they are inhaled or ingested, what happens is the sensitized individual usually produces this hypersensitivity reaction. So these individuals are called as atopic individuals. So the atopy individual are the one that have the ability to produce more amount of IgE antibody or the reagenic antibody, and it is genetically determined. That is, it often runs in the families. So it is not towards a particular antigen. The main concern is not an allergen again over here. It is, the main concern is how the individual produces more amount of IgE antibody. So the host is most important here, whether he is a normal individual or a sensitized individual, whether he is able to produce IgG or IgE antibody. So these individuals, those who are able to produce more amount of IgE antibody towards a common environmental pollutant, are called as atopic individuals, and they have the tendency to produce more amount of IgE antibodies. So let us see what is the difference between this IgE antibody and the other antibodies. So IgE antibody is usually very in a few amount in case of normal individual, but in case of sensitized individual, there is more production of IgE antibody. So this IgE antibody cannot be demonstrated in vitro by normal or the classical experiments. They can be demonstrated or they can be seen only with the help of radioallergosorbent assay, which is called as a RAST, or you can also go with the help of passive agglutination, or you can go with the more sensitive detection techniques such as ELISA or the RIA. So IgE antibody being very rare in the normal individual and seen only in the sensitized individual, you can detect only with the help of more sensitive techniques. And this Ig antibody is homocytotrophic, that is species specific, whereas the other antibodies are heterocytotrophic, as seen in IgG antibody, which can go and bind to the other cells also. But here in case of Ig antibody, it is homocytotrophic, that is produced in an individual, goes and bind to the receptors of the same type of individuals. And it was first proposed by Pronis and Kushner, who gave us to detect the Ig antibody by a phenomena which is called as a wheel and flare phenomena. So when a serum is introduced in a sensitized individual, local wheel and flare reaction helps us to know the amount of Ig antibody that is produced in a sensitized individual. And these Ig antibody differs from the other, being very heat sensitive. They can be easily inactivated at a very low temperature, around 56 degrees centigrade, whereas the other antibody takes a longer temperature or a higher temperature to get denatured or inactivated. And these Ig antibody do not cross the placenta as seen in IgA antibodies, and they are the one that are produced only in sensitized individual. And it is atopic individual where you can see the decreased production of IgA antibody. So it was linked as though in a normal individual where IgA antibody or IgG protects the individual from the common antigens, here in case of sensitized individual, there is a similar pathway for the production of IgG and IgA antibody, but here there is a shift in the production of Ig antibody more in number in the sensitized or the atopic individual. So you can say that decreased production of IgG and IgA in the sensitized individual can lead to the anaphylaxis reaction, where instead of IgG and IgA being produced, it is the Ig that is mostly produced in the sensitized individual. Now this Ig being more having receptors on the mast cells in the basophil cell causes the degranulation and causes the type 1 hypersensitivity reaction. Now depending upon the portal of entry of the allergen, you can see those clinical manifestation in type 1 hypersensitivity reaction. Here in case of allergen entering via the eyes, it is conjunctivitis, where you can see complete secretion of the tears in the sensitized individual. You can see rhinitis affecting the respiratory system of the sensitized individual. You can see gastrointestinal symptoms where ingestion of certain substances such as milk, or you can see certain seafood towards which certain sensitized individuals are allergic to it. So the gastrointestinal symptoms is via the ingestion of certain component towards which the sensitized individual is allergic. And dermatitis when gaining an entry via the skin, and sometimes you can see the generalized manifestations can lead to localized reactions such as urticaria. Now coming to the type 2 hypersensitivity reaction, which is called as a cytotoxic or cytolytic hypersensitivity reaction. So the term is cytotoxic or cytolytic is used over here because the antibodies that are inducing the type 2 hypersensitivity reaction are the one that damages the cells or the cells of the human body, and the cells that are mostly target are the RBCs in type 2 hypersensitivity reaction. So it is mediated by IgG and very rarely IgM antibody. When they go and bind to the cell surface antigens, they usually produces a reaction that completely damages the cell, which is called as a cytotoxic effect. And here it is not only the antibody that is killing the cells, but it is along with the activation of the complement system and the mononuclear phagocytes. Now here the lysis of the RBCs, the clinical manifestation associated with type 2 hypersensitivity reaction are the lysis of the RBCs by anti-erythrocytic antibodies in autoimmune anemias, and the hemolytic disease of the newborn, which is called as the erythroblastosis fetalis. So these are the complications that are associated with type 2 hypersensitivity reaction. Apart from this, there are certain drugs that are mostly involved in inducing the type 2 hypersensitivity reaction. The most prominent one being the penicillin. So the penicillin usually goes and binds to the RBCs and makes this as a whole antigen. Now when this RBC associated with the penicillin is detected by the immune system, antibodies are produced against this complex, and the antibodies goes and bind and causes the cytolytic activity of the RBCs. That is, there is a decrease in the number of the RBCs of the human, leading to anemia. So sometimes these antibodies can also act as agonist and antagonist. So as already discussed, the antibodies goes and binds to certain receptor on the cells, enhancing the production of the hormones. Mostly the thyroid cells are usually affected, or the target organs of this agonist antibodies. They go and bind and they causes excessive secretion of the thyroid hormone, leading to Graves' disease. Apart from that, they can also act as antagonists called as blocking antibodies. They go and bind to the cell surface receptor and they inhibit the production of the hormone, which is called as the myasthenia gravis. The complication associated is myasthenia gravis. So this type 2 hypersensitivity is an intermediate between the hypersensitivity and the autoimmunity. So autoimmune diseases are mostly from the type 2 hypersensitivity reaction. Now coming to the type 3 hypersensitivity reaction, which is mediated by the immune complexes, and the clinical manifestations associated with this type 3 hypersensitivity reaction are the Arthus reaction and the serum sickness. Arthus reaction is a generalized or you can say the systemic manifestation which can be seen in a localized reaction. So in a localized reaction you can see the Arthus reaction, whereas the serum sickness is a generalized destructions of this type 3 hypersensitivity reaction. Now coming to the Arthus reaction, you can see the entry of the usually developed against the serum. So when an heterologous serum is introduced into the sensitized individual, you can see there is an edema, induration and the hemorrhagic necrosis. And the local manifestation is because of the generalized hypersensitivity reaction, and this being from the humoral immune response, this can be transferred passively from one individual to the other individual. And the clinical syndromes that are associated with this anaphylactic reactions are when the sensitized individual inhales the thermophilic actinomycetes from the moldy or hay, they can develop farmer's lung and can also lead to pneumonitis. Now coming to the mechanism how these Arthus reactions usually takes place. So as said, it is an immune complex mediated type 3 hypersensitivity reaction. So when the allergen, especially the serum, when it enters, there is an antigen antibody complex that is formed, and these antigen antibody complex usually keeps on circulating and they activate the complement system, and apart from complement system they can also activate the inflammatory response. So there is an exaggerated inflammatory response during this course of antigen antibody complex that are formed, and due to this you can also see a vascular increased vascular permeability, neutrophil infiltration. Now these antigen antibody complex goes and hides themselves in various parts of the body. So during the extraction process of this antigen antibody complex, it so happens that the damage is more to the host rather than the antigen antibody complex. So when there is a neutrophil infiltration wherever this antigen antibody complex are hidden, you can also see there is a reduced blood supply by the leukocyte platelet thrombi, ultimately causing the tissue damage and the necrosis. So the complication in case of Arthus reaction is localized, and the antigen antibody complexes minute enough to go and hide themselves within the blood vessels or at the lining of the blood vessels. So this activates the inflammatory response, and during the extraction of this antigen antibody complex from these endothelial cells, they causes the damage to the host. So that is a localized reaction, which is an Arthus reaction. Now coming to the serum sickness, here it is a systemic type of hypersensitivity reaction, and the culprit over here to induce this serum sickness or the generalized hypersensitivity reaction is the foreign serum, especially the diphtheria antitoxin in sensitized individual. And the clinical syndromes or the symptom associated with this type 3 hypersensitivity reaction is its fever, lymphadenopathy, splenomegaly, arthritis, glomerulonephritis, endocarditis, vasculitis. You have urticarial rashes, abdominal pain, nausea and vomiting. So here again the immune complexes usually circulate throughout the whole body, and they can deposit themselves at any place in the human body, and the pathogenesis, as discussed is mediated by the immune complexes. So it is the serum, heterologous serum when introduced helps in the production of antibodies. So there is antibody towards the antibody. These antibody usually causes the forms the complexes, and they usually activates the type 3 hypersensitivity reaction, that is a systemic anaphylaxis. So during the course there is a lowered complement concentration, because whatever the complements that are already present, they go and bind to the immune complexes, and hence there is a lower level of this complement that can be seen during this serum sickness. And here this type 3 hypersensitivity systemic anaphylaxis is said to be self-limiting, that it goes off depending upon how the person reacts to that particular immune complexes. So immediately as the immune complexes are formed, there is more production of antibodies, and these antibodies makes the immune complex a larger one, so that they can be phagocytized easily by the phagocytes, that is the macrophages or the neutrophils. And the most important thing here is a latent period of 7 to 12 days after a single injection of the heterologous serum, you can see the clinical manifestation. And here this hypersensitivity reaction differs from the other, where a single dose is enough to show the systemic anaphylaxis. There is the sensitizing dose and the shocking dose is only one. Single injection is enough to show the systemic anaphylaxis. And the immune complexes are also produced not only by the heterologous serum, but also can be induced by different types of bacteria and the viruses, that is mostly the streptococcus, that is the causes post-streptococcal glomerulonephritis, hepatitis B, malaria, etc. Apart from that, nephritis and arthritis can also induce this type 3 hypersensitivity reaction. Now the last one is the delayed type of hypersensitivity reaction, that is a type 4 hypersensitivity reaction mediated by the cells or the T lymphocytes. So it is a cell mediated immune response that is developed in the sensitized individual that produces this delayed type of hypersensitivity reaction. And it's so called delayed because the clinical manifestations to develop takes around days to weeks or months to show the symptoms. So that's why it is called as a delayed type of hypersensitivity reaction. And this is usually provoked by intracellular microbial infection, mostly seen in the tuberculosis, where the bacilli has the ability to multiply intracellularly in macrophages. Or it can also be induced by certain haptens like chemicals when applied on the skin, mostly in case of cosmetics or certain drugs or poison ivy from the trees. When they contact the skin, they causes the delayed type of hypersensitivity reactions. And here there is no involvement of any antibodies, and it is completely towards the cell mediated immune response. And the cells that usually get sensitized are the T cells. So sensitized T cells are the one that mediates this type 4 hypersensitivity reaction by producing the cytokines, which shows the biological effects on the leukocytes, the macrophages and the tissue cells. So once the sensitized T cells are usually formed following the antigen contact with the antigen, they usually activates the other cells, that is the leukocyte, macrophages and the tissue cells, by producing the lymphokines or the cytokines. And this cannot be transferred passively because no antibodies are involved, but can be transferred when the lymphocytes such as T cells, that is the Th cells, and the Tc cell, which are the mediators of type 4 hypersensitivity reactions, are passively transferred. And the two types of delayed type of hypersensitivity reactions are known. One is called as the tuberculin or the infection type of delayed type of hypersensitivity reaction, and the other one is a contact dermatitis. So coming to the tuberculin or infection type of hypersensitivity reaction, this tuberculin reaction usually takes place in the sensitized individuals towards tuberculoprotein. So when this tuberculin is injected intradermally into the sensitized individual that are already infected with a particular disease, or they are immunized with that particular disease, they show the delayed type of hypersensitivity reaction. No such response can be seen in unsensitized individual. So this helps us to know the state of delayed type of hypersensitivity reaction towards the bacilli in an sensitized individual. And here the subacute or the chronic pathogenic intracellular organisms are the one that shows the delayed type of hypersensitivity reaction. So this tuberculin can also be used to identify the delayed type of hypersensitivity reaction caused by different bacteria, viruses, etc. Apart from that, you can also identify the delayed type of hypersensitivity reaction associated with the allografts, that is transplantation of the tissues that are usually rejected. So in that case also you can see the delayed type of hypersensitivity reaction, and also in autoimmune diseases. Contact dermatitis is another type of type 4 delayed hypersensitivity reaction that can be provoked when the skin comes in contact with certain types of chemicals such as nickel, chromium, dyes, picril chloride, you have dinitrochlorobenzene. Or apart from that, you can also see when the drugs such as penicillin and toiletries comes in contact with the skin. So penicillin is said to be the one that can mediate all 4 types of hypersensitivity reactions. And here the chemical is a hapten that itself is not antigenic in nature, but when it combines with the skin protein it becomes antigenic in nature. And there is a sensitization phase where usually occurs when there is an inflamed area, or when the antibiotics are usually applied on an oily base, etc. So here you can see there is a percutaneous absorption of this antigen, that is the hapten, along with the skin protein, that is usually carried out by the taken up by the Langerhans cell. So in order to activate the cell mediated immunity, you need to have antigen presenting cell that can present the antigen to the T cell and make the T cell sensitive to cause the type 4 hypersensitivity reaction. So here the antigen presenting cell are the Langerhans cell that usually reside subcutaneously, and when the antigen enters via the skin, Langerhans cells carry them to the regional lymph node where the antigen is presented to the MHC molecule, the process presented to the T cells, and the T cells discriminates or differentiates itself via the 2 pathways, that is the TH1 or the TH2 pathway. In the TH1 pathway, the cytokines that are produced are the interferons or the interleukin 2, which helps in activating the macrophages or the lymphocytes that are central in the development of delayed type of hypersensitivity reaction. Now coming to the type 2, that is the TH2 differentiation, they can activate interleukin 4, interleukin 5, GM and the CSF, colony-stimulating factors, and these pathways usually activate the eosinophils or the lead to the tissue damage. So irrespective of whatever the activation is, ultimately the T cell becomes sensitized and causes the delayed type of hypersensitivity reaction. So here the allergen is nothing but a chemical, a simple chemical that when comes in contact with the skin protein becomes an antigenic in nature and causes a delayed type of hypersensitivity reaction. So here the clinical manifestations that are usually associated with the contact dermatitis are the development of macules and papules, which later on becomes they form the vesicle, and which breaks down and ultimately causes the acute eczematous dermatitis. So you can see the clinical manifestation completely on the skin, and this can be easily detected with the help of a patch test where the allergen is introduced, and you can see a local reaction appearing within 4 to 5 hours, and later on these being forming blisters ultimately within 24 to 28 hours. So this is how the contact dermatitis test can be done, which is called as a patch test. So this is all about the hypersensitivity reaction, and it is nothing but you can see the protective role of the immune response to defend against different types of pathogenic organism. But sometimes the immune response can go awry and causes an exaggerated immune response, which is called as a hypersensitivity, and only in sensitized individual which are called as the atopic individual.